Welcome to AETCM, the emergency medicine channel. It's a case of 65-year-old female with non-case of diabetes hypertension presented to ER with complaints of slip and fall, post which patient complaints of right-sided hip pain. Initial 10-second assessment. Airway was patent with no hoarseness, gargling or stridor. Breathing wise, respiratory rate is 18 per minute. Saturation of 100% with bilateral air entry present. Circulation, heart rate is 84 per minute with a BP of 130 per 70 with the S1, S2 present. All peripheral pulses palpable. Disability wise, GRBS is 180 per milligram per DL. With the exposure, patient is afebrine. So history of presenting complaint.
Pain score?
Pain score was 8 by 10. So we initially given pain medication like injection tramadol with MCIT we given for pain. So history of presenting complaint, patient is a 65-year-old female with non-case of diabetes hypertension presented to ER with complaints of with alleged history of slip and fall at home half an hour before presentation to ER. So post which patient was complaining of right-sided hip pain and not able to and restriction of movement and not able to walk. No history of any syncope, chest pain, palpitation, fever and fever or altered sensorium.
There was no head injury.
No head injury as such. And back injuries also not present. So on local examination, inspection, there is the limb, that is right lower limb, was shortened with externally rotated, and there is no joints like knee joint and ankle joint looks to be normal inspection wise. Then palpation wise, there was tenderness in the right groin area along with restriction of movement. Patient is having severe pain when we try to flex the hip joint. Along with distal pulses were palpable. Distal joints like knee joint and ankle joint appears to be normal in palpation as well as mobility, range of movement. Then movement, as I said, range of movement was restricted in hip joint and other joints were fine, normal only. So since patient was having restriction of movement with externally rotated limb, we went to an X-ray pelvis, AP and lateral view. There we found that there is a neck of femur fracture in the right femur with no dislocation of neck of femur fracture was there.
So this is a case where a 65-year-old female had a trivial fall following which she came with complaints of hip pain. So what are the things that suggest to you, what are the different types of fractures in the proximal femur?
In proximal femur, classification
basically you can classify fractures as
intracapsular and extracapsular.
Yeah.
So intracapsular include most of the femur, neck of femur and head of femur fracture, and extracapsular include intertrochanteric and subtrochanteric fracture. So
what is the difference? What are the main difference if it is an intracapsular fracture?
Okay, the intracapsular fractures have a high rate of malunion and non-union. Along with mostly the vascular structures can be more prone to injury in the intracapsular fracture. So we also have
risk of vascular necrosis of femur, malunion, non-union risk is very high. And what about intertrochanteric fractures?
Intertrochanteric fracture heals better.
Why?
Because it's vascularity will be present.
And cancellous bone is more in intertrochanteric space. So, and the blood supply is also better. Much better than intracapsular fractures. So, those fractures tend to heal better. And if you properly reduce and fix initially, you can the prognosis and the healing part occur very fast. So that is intertrochanteric fracture. Okay, so how will a patient present with a fracture of femur, neck or head or intertrochanteric fracture to you?
Most of the patient presented with alleged history of slip and fall or a twist injury to the patient's foot or a sudden spontaneous completion of a fatigue followed which
intertrochanteric fracture normally occurs in old age people. It is very rarely seen in younger age people. In both fracture neck of femur and intertrochanteric fractures, in both if the fractures are displaced, it will be shortened and externally rotated. So the external appearance of the limb, with seeing that, you can't distinguish whether it is neck of femur or intertrochanteric fracture. And what about the external features? You will see swelling, patient will have severe pain, and there will be ecchymosis, which will be more in which of the fractures it will be more? It will be more in intertrochanteric fractures compared to femoral fractures. Why? Because in intertrochanteric fracture there is very high chance of blood being pooled up in the area, in the inner thigh, and the ecchymosis part will be much higher, much more than in fracture neck of femur. So, but all the other features, if it is a displaced neck of femur fracture, it will be seen as same as that of an intertrochanteric fracture. Patient will have severe pain, limb will be shortened and externally rotated. You can see ecchymosis, very severe tenderness. So what to do? You should not. Traction is contraindicated in both the cases because of the high risk of avascular necrosis, and you will cause further damage. So you you ask the patient to keep the limb in his or her position of comfort, and first thing what to do is pain management. What is the preferred way of pain management?
IV analgesics can be given as well as blocks can also.
IV opioids are much more preferred because of the severity of pain, and you can, if preferable, if you can give a regional nerve block, will be better choice of analgesia in such patients. Okay, so you suspect a intertrochanteric or a fracture neck of femur or any of the trochanteric fractures, so, and you give a pain management. What is the next thing to do? Proceed with the investigation. So what are the X-ray films that you will order for?
Most probably we can order an AP and lateral of hip.
AP view with complete internal rotation will give you a better view. If only AP view you can identify proper displaced fracture, but lateral view you can identify very subtle fractures can be seen in lateral view. Do you need X-ray pelvis? Pelvic X-rays?
Pelvic X-ray?
It is necessary to compare it if it's basically a neck of femur fracture and all. It is necessary to compare one hip with the other. So you normally advise to take an X-ray pelvis view. So what is that in an X-ray pelvis view that you see in fracture neck of femur? What do you see in the X-ray?
The angle will be disturbed.
Angle will be basically the Shenton's line. Shenton's line and all, it is like literature says that it is not very clinically relevant because it may vary with the position of the limb. The Shenton's line, it is not a diagnostic feature. If there is a break in Shenton's line, there is a fracture. It is not like that. So you basically look at the discontinuity of the bony cortex and the trabecular lines. This is what you see. So that is what you take an X-ray AP view with the internal rotation. You can take an X-ray pelvis, and you can take an X-ray lateral view of the hip joint. So these are the X-rays. Should we go for CT or MRI?
In case of occult fracture or minute fracture, we can go for.
As emergency point of view, if fracture is seen on the X-ray, then we need not proceed to CT or MRI. But you can give an orthopedic consultation after seeing the X-ray. Okay, so once you give an orthopedic consultation, what are the things that what will be the line of management of these cases?
Mostly a surgical fixation is most important because for neck of femur fracture due to risk of avascular necrosis. So open reduction and internal fixation we can try in a younger patient, but in older patient with more profuse injury, we have to go for partial arthroplasty.
Ambulatory patients, very young patients, if they come with fracture neck of femur, you can do dynamic hip screw and all you can do. You need not replace the entire hip. But the problem is the time for proper ambulation the time taken for the patient to walk after the surgery will be longer. But in old patients who is having already an osteoarthritic changes in the joint, you can do complete or partial hip arthroplasty can be done. Main thing to focus is that we should not give traction. action is completely contraindicated in these patients. What about intertrochanteric fractures? What do you do? That is also mainly surgical only. Surgical is open reduction, internal fixation. You know, in which type of patients you do not go for operative management?
In end stage management, like very
Those
old
with
patient.
terminal illness, those who are chronically non-ambulatory patients, bedridden patients, those with dementia, who is anyway not walking, and those patients who are having very severe comorbidities, elderly age groups and all, you prefer non-operative management than operative management. Anything else to add?
No complications include.
What are the complications and what type of fractures tend to have more complication? In the intracapsular fractures will tend to have more complications like infection. Patient will have a risk of avascular necrosis. This will be more for that. Yeah, there is a risk of thromboembolism. So you need to add DVT prophylaxis because patients will be on bedridden, no? And for OT purpose and all, we need to add DVT prophylaxis. So basically, as per our part, we need to know how to examine the patients. We need to take a proper X-ray, evaluate the X-ray, and then give the analgesic first, give an orthopedic consultation. After orthopedic consultation, you just need to know what is the line of management, and you have to add on DVT prophylaxis as well as antibiotics because these patients are at a high risk of infection. Okay.
Thank you.